Welcome to the AUA News Inside Track podcast, an official podcast of the American Urological Association. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.
Hi, everyone. Today, our episode will be on urologic reconstructive surgery. My name is Jake Tanawang. I am a current medical student at the University of Minnesota Medical School. I also serve as the student representative for the North Central section for the AUA's Medical Student Membership Work Group. I'm joined today by Dr. Sean Elliott. He is both professor and director of reconstructive urology at the University of Minnesota. He graduated medical school at Baylor College of Medicine and completed both his residency and a fellowship in genitourinary trauma and reconstruction at the University of California, San Francisco. Dr. Elliott also serves as president of the Society of Genitourinary Reconstructive Surgeons. His current practice includes a focus on urethral stricture disease, urinary diversion, and specifically neurogenic bladder for people with spina bifida or spinal cord injury. Dr. Elliott, thank you for being here.
Thank you, Jake. It's a pleasure to be here.
So firstly, for the medical students who are not familiar with reconstructive urology or who are trying to gain more exposure to the field, can you share with our audience what genitourinary reconstruction is?
Sure. Well, in one sentence, we rebuild parts of the genitourinary tract that are injured by disease or trauma or congenital abnormalities. Whereas other diseases other fields are united around a disease such as cancer or stones, reconstruction is different in that we care for a variety of diseases. We care for victims of trauma, iatrogenic injury, gender dysphoria, neurogenic bladder, and these are all really disparate diseases that have little in common with each other. It's really the field of reconstruction that unites these diseases under one subspecialty. And what unites all of them together is that reconstruction is dedicated to the craft of surgery. So we're experts of using flaps and grafts and intestinal segments to restore function. We are dedicated to delicate tissue handling skills, and we're experts in prosthetics.
Absolutely. That's really fascinating. Yeah, reconstruction as a field is not monolithic. And I know, at least from my time rotating as a medical student, there are a variety of cases and they're all like really fascinating. And so like you mentioned before, I mean, there are many specific pillars that make up the field as a whole, from robotic surgery to even gender affirming care and trauma. Can you tell us about your specific practice and what makes it unique?
My practice is dedicated to about, I'd say 50 to 70% of it is urinary diversion. I take care of adults with spina bifida, spinal cord injury, cerebral palsy, other neurogenic bladder conditions that are fairly operative. I focus on those ones that would benefit from bladder reconstruction using intestine. So we will enlarge the bladder for people with small, high-pressure bladders using intestine to do a bladder augment. We'll use intestine to create a catheterizable stoma so that someone who needs to catheterize to empty their bladder can do that while they're still in their wheelchair by catheterizing through their navel. And then the balance of my practice is urethral stricture disease, which is scar tissues of the urethra, and we use flaps and grafts to rebuild the urethra to relieve blockage of the urinary stream. And then artificial urinary sphincter, which is a prosthetic device that helps with male incontinence.
Okay, really cool. Can you share like what a typical week looks like for you? What are your hours like? How much time is spent in the clinic versus the OR?
Yeah, I'm sure this is not necessarily characteristic of every reconstructionist, but my typical week on average is about 1.5 days of clinic, about half a day of administrative or research time, and about 3 days of operating.
Okay. You kind of touched on this earlier, but what are like the bread and butter cases in recon, and are any of these in particular your favorite?
Uh, the bread and butter would be urethroplasty. Uh, if you think back 20 years, Jake, to when I was a fellow, reconstruction really was urethroplasty, prosthetic surgery, which is inflatable penile prosthesis and artificial urinary sphincter, and Peyronie's disease. That was like 90% of reconstruction. And it's changed a lot over time, adding all these other niches that you and I just talked about. But yeah, those things remain the bread and butter, those things that were around when I was a fellow.
Okay. Do you have a particular favorite case that you like to do?
My favorite, um, well, I should back up and say that I operate on a lot of people with complex abdominal anatomy with lots of previous operations. I think you've scrubbed in on some of them before.
Mhm.
Um, they've had colon added to their bladder and they've had appendix added to their bladder, and then that's been removed and a new stoma has been made out of a piece of small bowel instead. And we always do our darndest to read all of the old op notes and figure out what exact intestinal segments were used. And we do our due diligence. But one of my favorite surgeries is when we've done our best. We can't figure out everything about the person's anatomy before we go in there, and we just have to open them up and figure it out when we get there. We know that they've had a bladder augmentation, but we don't know if it's from the small bowel or the large bowel, and we have to trace the mesentery and figure it out. It's what you might call black box surgery. Um, for the people listening, one of the greatest medical books, I think, is Cope's Diagnosis of the Acute Abdomen. You can still get it on Amazon, and it's like 100 years old. And it talks about how uh, different physical exam findings can help you figure out if someone has appendicitis versus cholecystitis. And, it's a lot of the art of surgery that's been lost with CT scanners and other things to help us arrive at a diagnosis. And so I think that black box surgery harkens back to that time when you just had to open them up and figure it out. And so that's a fantastic challenge and fun for me.
Okay. Well, I think I know what I'm gonna do. I'll log on my Amazon account now. I'll
Yeah.
order that book. Um, I'd be remiss if I didn't ask about how you got interested in reconstruction, and is there any experience that you had in your training or in medical school that really drove your desire to be a reconstructionist?
Yeah, definitely. I think like a lot of people, I wanted to emulate my mentor in residency. His name is Jack McAninch, and that was at the University of California, San Francisco. I admired the way he handled the tissue in the operating room. I admired the way he could take a resident through a surgery and make them feel like they were doing the whole surgery, when in fact he was just putting the tissue between their scissors while they were cutting, and he was making sure everything was going well for the patient. I admired that he was able to conduct a productive research career at the same time as caring deeply about his patients. And he was a great role model. And that sparked my initial interest in reconstruction. And then when I started to get knee deep into it, I started to realize that I enjoyed surgeries that restore function. I think everybody obviously gets into surgery for different reasons, but for me, I didn't care so much about saving lives by removing cancer. For me, I wanted to restore function. And I feel like in reconstruction, the goal is always to make someone better than they were before you operated on them.
Mhm.
Um, and so that's a great challenge and one that I enjoy.
I'm sure, with your focus on neurogenic bladder and things like that, the relationship that you've had and you've built with patients has been really impactful, both on their quality of life um, and your clinical practice. Can you speak more to how reconstruction as a whole impacts the patient-provider relationship?
Yeah, I think that we all enjoy being in the operating room, and that's why we've become surgeons. But if you just clock in and out of the operating room every day and don't develop relationships with your patients, you burn out pretty quickly. And some of the diseases I care for are more what you would call episodic care, meaning that someone shows up with a stricture, you fix it, success rate is 95%, and then you don't really see them much again after a 3 or 12-month follow-up. Those are great because it's great surgery and not a lot of follow-up. So that's rewarding in its own way. But it's also super valuable for me to have the patients that we follow over their lifetime because they have neurogenic bladder. And we do annual surveillance ultrasounds, and you get to form a relationship with the patient over time. You get involved in disease prevention instead of just disease management,
Mhm.
and you get to watch them grow up and have families and meet their families. So that's a little bit of maybe like the family practice doctor in me that comes through. Uh, and that's one of the reasons I became a urologist and not an orthopedic surgeon, let's say, because I did want to have some patient relationships.
Did you get any exposure into recon when you were a medical student at Baylor?
At Baylor in Reconstruction, let's see, Baylor was very heavy into oncology, and that's really what I fell in love with when I was a medical student. And it wasn't until I got to residency that my eyes really opened up and I saw what Reconstruction was all about.
Okay. Kind of switching gears a little bit. Is there any advice that you have, or what do you want medical students who are rotating with you, or for those students who are potentially thinking about pursuing a GERS fellowship at some point in their career? What advice do you have for them at this point?
I would say just soak up every single learning opportunity you have. Be like a sponge. You'll you'll be shocked at how much each of those learning experiences will help you later. I think oftentimes we're in a hurry to subspecialize quickly and devote ourselves just to the area of, say, reconstruction. But when you're on an OB rotation, there's so much you can learn that's going to help you 20 years from now. And when you're on a cardiothoracic rotation, there's a ton you can learn about physiology and how to sew. So throw yourself into every single experience and try and learn as much as you can would be my best advice. And then the other part to your question was, what do I hope to teach the med students as they're on rotation with me, or the residents when they're on rotation with me? I would say that in that case, I know that most of them aren't going to become reconstructive surgeons when they're all done. And so it doesn't really matter if at the end of the day, if they know how to do a urethroplasty. What matters is, do they know how to hold a needle driver precisely? Do they know how to tie square knots? Do they know how to position their body at the table so that they have good ergonomics and can have a steady hand while they're sewing? So I focus on a lot of those things because I think as reconstructionists, we are dedicated to the craft of surgery, and I take it as an opportunity to focus on those aspects as I work with the trainees.
So a lot of the fundamentals are really important. Uh,
Definitely.
okay.
And, important in all of surgery, but we seem to be, or at least I'm definitely uniquely interested in them in our subspecialty.
Dr. Elliott, you are the founder of the GERS Fellowship at the University of Minnesota. Can you share what type of training that a GERS Fellowship entails? And like, what is the scope of a generalist compared to what fellowship training enables you to do?
Yeah, so a general urologist, I'm generalizing here, but you're probably in the clinic more often than you're in the operating room. That's not to say that you aren't doing a lot of procedures, because there are a ton of clinic-based procedures, but by subspecializing, you oftentimes are learning more advanced surgical skills, and no matter what that subspecialty is, it might be a way to have a more operative practice and less clinic-based. And that has pluses and minuses to it that I think we all have to think through. There's certain quality of life benefits to having a clinic-based practice versus a surgical practice. I go out of town, but I stress about my patients who are still in the hospital. So you have to think about what works best for you. Um, but that is that's one difference. I'd say the typical tract for someone who's doing reconstruction is to apply in the second to last year of their residency, and they do interviews in the springtime of that second to last year. And then there's a match in the summer before they start their last year of residency, and they know where they're going in July, and so they have a year to plan ahead. Uh, Almost all the fellowships are 1 year with a little bit of protected research time, maybe like half a day or a day. They're all very surgical or very operatively focused. There's one, maybe two fellowships that offer a 2 year tract with a research year, but it's a very surgically focused subspecialty.
Okay. Are there any personality traits or characteristics that you think make someone a good fit for a career in recon?
Um, I think that you have to, like any challenging surgical field, you have to be uh, you have to be a little bit OCD, and definitely 90% of surgical success happens before you get to the operating room. You have a good surgery because first of all, you decided to operate on the right patient and you counseled them appropriately and you made sure the operating room was set up correctly. So a lot of those obsessive qualities are important. I think compassion is very important, and that's not all that different from any other subspecialty within urology. I think as all of us urologists form deep bonds with our patients because we're caring for sensitive parts of the body.
Okay. Switching gears a little bit, clinical research has been a huge part of your career and is one of the core pillars of the GER Society. What role does research play in shaping the field as a whole, do you think?
Just like the field is not limited to any one disease, the research field is also wide open. You've got everything from the basic science of wound healing to prosthetic device design to health services research with big data to clinical trials. So really, it's just about anything. I've enjoyed mostly health services research using big data like SEER Medicare data sets to answer population health level questions. But I've also been involved in some device design and testing, clinical trials of, a new drug-coated balloon to treat urethral stricture disease. I've done less of the laboratory basic science work in my career, but now I'm starting to get more into that with understanding what leads to recurrent UTIs in people with bladder augmentation.
Okay. And then kind of in the same vein, like what are the current trends or what really excites you about the future directions for recon?
I think that it's really limitless. We've hinted at this earlier, but over the course of my career, I've seen reconstruction grow from being, if you will, sort of a below the belt surgery. It was all penile prostheses and urethroplasties. And over time, we've added gender affirmation, genital surgery. We've added robotic intra-abdominal reconstruction. We've become the experts in urinary diversion. And of course, we've always been the experts in GU trauma. So that trajectory has been really fun to watch and to be a part of, to see a field that just keeps growing, I think, because it's not limited to one disease set and we can flex and take on new things. To someone, in your age group, it probably seems like we've always been doing robotic reconstruction or we've always been doing gender surgery, but these things have just been added in the last 5 or 10 years to our subspecialty. And so uh, from my vantage point, I can say that in the next 5 to 10 years, we'll probably add 1 or 2 more areas that we haven't explored yet. And I don't know what those areas are going to be yet. I think that's going to be your generation that's going to figure it out, and it's going to be really exciting for me to watch.
Okay, keep your eyes open.
Okay.
Dr. Elliott, this has been really, really special and really informative. Is there anything else you'd like to share with our audience before we close?
I think the last thing I'd say is, what's the most challenging part of being a reconstructionist? I'd say it's being the patient's last hope. We've talked several times about how our job is to restore function, and all of us around the country frequently see patients who come to us in our reconstruction practice and say, Dr. So-and-so sent me to come see you, and they said you walk on water, and they said you're going to fix my XYZ problem, but you review their chart and it's not looking so good. You're not so sure that operating on them is the right thing to do. And it's always easy to operate. The hard choice is deciding when not to operate, and it's even harder to convince someone who thinks that you're going to fix them that they are not going to have surgery. So knowing when not to operate and knowing how to communicate that to patients is one of the hardest things we do. And you can't let your ego get in the way and tell you that you can always fix everything.
Kind of that setting expectations is really important for patient care and shared decision making. I like that.
Indeed.
Dr. Elliott, thank you so much for your time, and thank you everyone for listening. We hope you enjoyed today's podcast. If you'd like to learn more about the Medical Student Membership Work Group, please visit the AUA website or email us at medstudentmembership@auanet.org. Thank you.
Thank you.
This has been an AUA News Inside Track podcast. To hear more episodes of this podcast, visit www.auanet.org/podcast.